Hi everyone, am I audible and visible? If I'm audible and visible, can I get a quick thumbs up? Hi Medicaholic Study Corner. So good evening all of you. This is Dr. Shanmugapriya, a PrepLadder faculty for Biochemistry, and as you all know, this is an FMGE 2023 Biochemistry recall session. And I would like to begin the session with a disclaimer that all the MCQs that will be discussed in this presentation are purely based on recollection from you all. And the aim of this session is to collect the exact question. So anytime you can stop me during the discussion if the choices are wrong or if the question is wrong, I'll be always happy to change that and give you the right key. Okay, so after everything is done, the final questions with the discussion will be uploaded on the PrepLadder app. So that's a disclaimer. And before we start the session, I would also like to tell you something. Though this is a recall session, this is not going to be just a session wherein I will be giving you the key for all the questions. Because your presence here by itself tells you how motivated you are, how focused you are. I am very sure that you will be clearing this FMG exam and you'll be soon appearing for NEET exam. So you will want to know the related facts and concepts. So every question discussion will be elaborate in terms of, I will be telling you all related facts and concepts as well. Okay, so that's about this session. Yes, this is helpful for NEET PG as well. Hi all of you. Hi Himanshu. Yes, this is helpful for NEET PG. Okay. Hi Tarun. Seeing you after a long time in my session. So that's an introduction to this session and this is the first question. So the first question is, which of the following pathways only takes place in a cell cytoplasm? What do you think is the right answer? What did you answer? Hi Ram Saini. Yeah, what did you all mark as the right answer? Hi Rehan. The right answer here is glycolysis, right? Because glycolysis happens in cytoplasm. How about other choices? Very good, Subham Kumar Tripathi. Very good. Yes, glycolysis is the right answer. How about choice B? Beta oxidation. Beta oxidation of fatty acids happens where? It happens in mitochondria. So how to remember this? We know that oxidation is supposed to happen in mitochondria. The only oxidation which happens in cytoplasm is glycolysis. Because the only oxidation which is anaerobic is glycolysis. So glycolysis alone happens in cytoplasm, whereas every other oxidation is bound to happen in mitochondria. And do you think all fatty acids undergo oxidation in mitochondria? Do you think all fatty acids undergo oxidation in mitochondria? No. When it is a very long chain fatty acid, it undergoes oxidation in peroxisome. So what are the other functions of peroxisome? Because this has been frequently asked in NEET PG and FMG. Let's try to recollect what are the other functions of peroxisome. One is it is related to very long chain fatty acid oxidation. Second one is ether lipid synthesis. Have you all heard of plasmalogens? Yeah, plasmalogens are synthesized in peroxisome. And apart from ether lipid synthesis, they are also related to branch chain fatty acid oxidation. They also help in glycine and taurine conjugation of bile acids. So what are the functions that peroxisomes are related to? Very long chain fatty acid oxidation, branch chain fatty acid oxidation, ether lipid synthesis, glycine and taurine conjugation of bile acids. Okay, so that's about peroxisomes. And how about Shailesh? Very good, plasmalogen, you're right, yes. So how about citric acid cycle? Citric acid cycle happens in mitochondria. Okay, how about urea cycle? We know that the first two steps of urea cycle happen in mitochondria. The remaining steps happen in cytoplasm. So urea cycle happens both in mitochondria and in cytoplasm. Very good, Somraj Majumdar, you're rocking it, yes. So can we fill up this tabular column? Once you fill up this tabular column, then you're very clear about the pathways and the suborganelles wherein this happens. Okay. So let's start with glycolysis. In which suborganelle glycolysis happens? As you all told me, it is cytoplasm. And how about pyruvate dehydrogenase complex that is present in mitochondria? Can you all continue answering, please? Yes. Citric acid cycle happens in mitochondria. How about glycogen metabolism? Be it glycogen synthesis or glycogenolysis, both these pathways happen in cytoplasm. So the entire glycogen metabolism happens in cytoplasm. How about gluconeogenesis? I want you all to remember that gluconeogenesis involves three suborganelles. The first step happens in mitochondria. Yeah, the first step, one second. The first step happens in mitochondria, the remaining steps happen in cytoplasm, and the last step, which is catalyzed by glucose 6-phosphatase, is in endoplasmic reticulum. So gluconeogenesis is one pathway which involves multiple suborganelles. First mitochondria, remaining steps in cytoplasm, finally glucose 6-phosphatase is in endoplasmic reticulum. Very good. Excellent, Kadir. Good. And then HMP shunt happens in cytoplasm. How about fatty acid synthesis? That is also cytoplasm. Just now I told you about fatty acid oxidation. Where does it happen? Oxidation happens in mitochondria. What is the exception? Very long chain fatty acid oxidation alone happens in peroxisome. So it is either in mitochondria or in peroxisome. How about ketone body synthesis? I hope you all know that ketone bodies are products of incomplete oxidation of fatty acids. So it is a byproduct of it. So where do you think it will get synthesized? The same place wherein fatty acids get oxidized. So ketone body synthesis also happens in mitochondria. How about cholesterol synthesis? Can you all continue answering please? Cholesterol synthesis. Will you agree with me if I say cholesterol is a steroid? All of you, will you agree with me if I call cholesterol as a steroid? And which suborganelle is related to steroid synthesis? It is smooth endoplasmic reticulum. So few steps of cholesterol synthesis. The first few steps of cholesterol synthesis happens in cytoplasm. The remaining steps happen in smooth endoplasmic reticulum. Please memorize it. Okay. S for S, smooth endoplasmic reticulum is related to steroid synthesis. Bile acid synthesis, again a steroid. Where will it be synthesized? It will be synthesized in the same endoplasmic reticulum as where cholesterol gets synthesized. Okay. Now about urea cycle, just now I told you the first two steps of urea cycle happen in mitochondria, the remaining steps happen in cytoplasm. And heme synthesis, similar to urea cycle, out of the 8 steps of heme synthesis, 4 steps happen in cytoplasm and 4 steps happen in mitochondria. Is that clear? So that's about the suborganelles and the pathways. I want you to remember oxidation happens in mitochondria, glycolysis happens in cytoplasm, gluconeogenesis involves cytoplasm, mitochondria and endoplasmic reticulum. Smooth endoplasmic reticulum is related to steroid synthesis. Okay. Now the next question. So how did you all feel about this paper? Yeah, how did you all feel about this paper? I would say there was a right combination of every type of question. There were recall based questions, simple recall based questions like what we discussed now, right? Glycolysis happens in cytoplasm. And then this question, which of the following is not a micronutrient? Purely recall based. But at the same time, there were also clinical case based MCQs and image based MCQs. So I would say this question paper had a right combination of every type of question and every level of difficulty was also represented. For example, in biochemistry, there was one question on P43. How many of you saw that question? Yeah, so that is, will you all agree with me when about what I said now? Yeah, so it was a right combination. Yes, all of you have started answering. Yes, it is calcium. So the right answer for this question is, it is calcium. So what do you mean by micro element and what is a macro element? Micro element or micronutrient is something requirement of which is less than 100 milligram per day. Do you understand this? Micronutrient is something requirement of which is less than 100 milligram per day. So this list will obviously include all vitamins. And among minerals, what are the micronutrients? The most famous one, iron. Right? Iron is a micronutrient. And then copper is a micronutrient. Zinc, molybdenum. Yeah, zinc, molybdenum. All these are micronutrients. Now what are macronutrients? If requirement of a nutrient is more than 100 milligram per day, that is called as a macronutrient. Example will be the answer for this MCQ. What is it? Calcium. Because the daily requirement of calcium can be anywhere between 1000 and 2000 milligram per day depending upon the age. It is more than 100 milligrams. So please remember calcium is a macronutrient. Not only calcium, magnesium. Okay, calcium, magnesium, phosphorus and potassium. Okay, all these are macronutrients. So please remember this list. Okay, so answer is calcium. Now the next question, I hope all of you have answered it right. Yeah, it's a very simple question, right? Melanin is synthesized from which of the following amino acids? What is your right answer? The right answer is tyrosine. Yes, because what is that? Tyrosinase is the enzyme which can convert tyrosine to melanin. And apart from melanin, what are the other specialized products? Excellent, all of you. Very good, Megha, Majumdar, Hiram, Saini, Tripathi. Excellent. So apart from melanin, what are the other specialized products that you can expect from tyrosine? Tyrosine is also a source of many neurotransmitters. Starting from dopamine. From tyrosine, you can synthesize dopamine, norepinephrine, epinephrine. So it helps in the synthesis of neurotransmitters. It is also necessary for synthesizing thyroid hormone. Yeah, so this list you should have in your memory. Now what about the other choices? Can we try to exclude other choices? How about tryptophan? What are the specialized products that you get from tryptophan, all of you? From tryptophan you get niacin. That is why we say 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So one specialized product that you get from tryptophan is niacin. Apart from niacin, it is also serotonin. What is serotonin? It is 5-hydroxytryptamine. So you get serotonin and niacin from tryptophan. Excellent. And then leucine. Do you get any specialized products from leucine? No. All that you need to know about leucine is that it's a branch chain amino acid. Leucine is a branch chain amino acid and it is purely ketogenic. What are the two purely ketogenic amino acids? One is leucine, the other one is lysine. So all of you, those who are attending this session, if your aim is NEET PG or if your aim is to clear the next FMG, irrespective of that, my assurance to you is by the end of the session, you would have memorized at least 100 facts. And you would have understood at least 50 concepts. Okay, so please be patient, listen to this carefully. So leucine is a branch chain amino acid and it's purely ketogenic. And then phenylalanine. What are the specialized products? NEET PG, very good, Megha. My best wishes. Okay, so phenylalanine. What are the products that you get from phenylalanine? From phenylalanine you get tyrosine. From tyrosine you get melanin. From tyrosine you get all these neurotransmitters and thyroid hormones. Okay. So this is the next question. Which of the following enzymes is found to be deficient in von Guericke's disease? Who wants to answer this? We know that von Guericke's disease is type 1 glycogen storage disorder. You can remember it as type 1 is von, right? So type 1 glycogen storage disorder is caused by the defect of excellent. Yes, it is glucose 6 phosphatase. I'm happy that most of you have gotten this right. It is glucose 6 phosphatase deficiency. Before we start discussing about all the other choices, I want you to know that glucose 6 phosphatase is an enzyme of both gluconeogenesis and glycogenolysis. Is that clear? Yeah, all this while you must have learned that glucose 6 phosphatase is an enzyme of gluconeogenesis. Please include glycogenolysis also in the list. So glucose 6 phosphatase is a common enzyme for both glycogenolysis and gluconeogenesis. If that is defective, it causes von Guericke's disease. Now tell me, what will be the presentation of von Guericke's disease if both glycogenolysis and gluconeogenesis are defective? These are the two pathways which can increase blood glucose. If both the pathways are defective, what will it present as? Yeah, it will present as everyone's favorite question. I know, Nikhil. You're right. If both the pathways are defective, what will it present as? It will present as hypoglycemia. Please memorize it. Von Guericke's disease presents as hypoglycemia. Now, how about branching enzyme defect? Branching enzyme defect is called as Anderson's disease. If you're asking me how to memorize, it's easy to remember, right? How is it easy to remember? A followed by B. A stands for Anderson's disease. B stands for branching enzyme. So Anderson's disease is caused by the defect of branching enzyme which is involved in glycogen synthesis. Can you think and tell me what will be the presentation when branching enzyme is defective? In liver, glycogen is synthesized without a branch point. So it occupies a larger space. Liver parenchymal cells are occupied by something which is very large. So it causes hepatomegaly first and that progresses to liver cirrhosis. So please memorize, Anderson's disease is characterized by liver cirrhosis. Is it not easy, all of you? Yeah, if you try to understand and learn, you don't have to memorize anything blindly. When you know branching enzyme is defective, it synthesizes glycogen without branch points. Branch points will make the glycogen compact. So now liver is storing glycogen without branch points, so the size is larger. Liver enlarges, that causes hepatomegaly first, that progresses to liver cirrhosis. That is about Anderson's disease. Now debranching enzyme defect causes which disorder, all of you? Yes, limit dextrins. Debranching enzyme defect causes Cory's disease. How will you remember it? C followed by D. Cory's disease is caused by the defect of debranching enzyme. Okay, so debranching enzyme is an enzyme of which pathway? It's an enzyme of glycogenolysis. And this debranching enzyme is common to both liver glycogenolysis and muscle glycogenolysis. When liver glycogenolysis is defective, blood glucose decreases. What is a major function of liver glycogenolysis? It is to increase plasma glucose. So when that is defective, Cory's disease will present with hypoglycemia. When muscle glycogenolysis is defective, that will cause exercise intolerance. So tell me, what are the two features of Cory's disease? Cory's disease presents with both hypoglycemia and exercise intolerance. Now the last choice is myophosphorylase defect. M for M. Very good Sudiksha. Yes. When muscle phosphorylase is defective, M for M, it is McArdle's disease. And now tell me, what will be the presentation when muscle glycogenolysis is defective? It will present as exercise intolerance. Okay, so that's about all these choices. Okay, so can we quickly fill up this tabular column about all glycogen storage disorders? Yeah, by the end of the session, every one of you should be able to answer any question on glycogen storage disorders. Okay, so what is type 1? Tell me the name, please. Let me use black color here. Yeah, what is type 1? 1 stands for Vaughan. So type 1 is Vaughan-Geerke's disease. Tell me which enzyme is defective in Vaughan-Geerke's disease. It is glucose 6-phosphatase, an enzyme of glycogenolysis and gluconeogenesis. What is type 2? Type 2 is Pompey's disease. And the enzyme which is defective is acid maltase. Pompey's disease is caused by the defect of acid maltase or alpha glucosidase. Got it? Yes, very good Megha, you're rocking it. Yes, Pompey's disease will present with cardiomyopathy. Okay, now type 3. Can you tell me which is the third alphabet? Third alphabet is C. So type 3, name starts with C, which is Cory's disease. It is caused by the defect of which enzyme? C should be followed by D. So it is caused by the defect of debranching enzyme. Okay. And type 4 is AB because C and D are already over. Now it is A and B. Type 4 is Anderson's disease, which is caused by the defect of branching enzyme. Can anybody tell me what will be the presentation of Anderson's disease, which I told you just now? Anderson's disease, branching enzyme defect will present as hepatomegaly followed by liver cirrhosis. Type 5, you reverse 5 and put it again. Yeah, what is it? M. Type 5 is M, McArdle's disease. Just now I told you McArdle's disease is caused by the defect of which enzyme? Muscle phosphorylase. Excellent. Yes, very good Deshmukh. Now type 6 is Hirsch's disease. Hirsch's disease is caused by the defect of liver phosphorylase. And finally type 7, which is Tarrow's disease. Which enzyme defect causes Tarrow's disease, all of you? Tarrow's disease is caused by the defect of phosphofructokinase 1. Okay, so that's all about the 7 types of glycogen storage disorders. I hope you all remember it now. Okay, so type 6 and type 7 I told you just now. Type 6 is Hirsch's, liver phosphorylase defect. Type 7 is Tarrow's, which is phosphofructokinase 1 defect. Okay, so that's all about glycogen storage disorders. Now next question. Okay, which of the following plays a role in collagen maturation? So I have a question for all of you. Thank you Megha, I'm happy that you're enjoying it. So my question for you all is, was choice A copper and zinc or was it only copper? Can anybody recollect and tell me? Was it copper and zinc or was it only copper? If it was copper and zinc, then I would go for choice B. Okay, so what is the right answer? As many of you have answered it, answer is choice B, which is ascorbic acid. So ascorbic acid and copper both are involved in collagen maturation because ascorbic acid or vitamin C is necessary for prolyl or lysyl hydroxylase enzyme. Do you all understand this? Ascorbic acid is necessary as a coenzyme for prolyl or lysyl hydroxylase, which is involved in the post-translation modification of collagen. Whereas copper is essential for lysyl oxidase. And lysyl oxidase is involved in collagen cross-linkage formation. So though we need both vitamin C and copper, if choice A was copper and zinc, then you can go for ascorbic acid. Is that clear? It was copper and ascorbic acid. If that was the choice, then that would be the best answer. Both copper and ascorbic acid are essential for collagen synthesis. So because for FMG and NEET PG, collagen is a favorite topic, I'm going to just tell you the nutshell of collagen synthesis, steps of collagen synthesis. Okay. So collagen synthesis, as far as collagen is concerned, I think you all know that it's a triple helix, right? Collagen is a triple helix and it is made up of 3 polypeptide chains, and each of those polypeptide chains will be called as alpha chains. So step number 1 is alpha chain gene will be transcribed and it will be translated as the polypeptide chain. And after the polypeptide chain gets synthesized, the next step is post-translational modification. Translation is over and then you're modifying the polypeptide chain. So you call it as post-translational modification. But before that, do you all know that alpha helix has got 1000 amino acids? Each and every one of these alpha polypeptide chain has 1000 amino acids. And these 1000 amino acids are distributed as glycine XY. So 30% of amino acids which are present in collagen will be glycine, and then it will be X and Y, where X and Y can be proline and hydroxyproline predominantly. Okay, so after the polypeptide chain gets synthesized, some of these proline residues and some of the lysyl residues will become hydroxyproline and hydroxylysine. And this is done by prolyl hydroxylase and lysyl hydroxylase. And this enzyme is a heme enzyme which needs iron. It needs iron to be in the center. And to keep iron in the ferrous form, you need vitamin C. That is why I keep telling you repeatedly, vitamin C is necessary for prolyl and lysyl hydroxylases as a coenzyme, because vitamin C keeps the iron in the ferrous form in these 2 enzymes. So following this, hydroxyproline and hydroxylysine will be synthesized, and then in Golgi complex they undergo glycosylation. After hydroxylation they undergo glycosylation. After glycosylation they form a triple helix. So far all these alpha polypeptide chains were getting synthesized separately. Now after they undergo hydroxylation, after they undergo glycosylation, these 3 polypeptide chains will get associated to form a triple helix, which looks like this. Can you see the triple helix here? So red, green and blue, each of these would represent every alpha chain. And what is formed is called as a pro-collagen. Why am I calling it as pro-collagen? Because in this pro-collagen, only the central part has formed the helix. Only the central part has formed the helix. On either side, on both the amino terminal end and on the carboxy terminal end, the helical structure is not formed. So you call it as pro-collagen. And in the form of pro-collagen, it gets secreted into the extracellular. What is it? Please explain in detail. It's good for us. Yeah, if you don't want to get a detailed explanation, you can later watch it. You can later watch it in a 1.5 mode or 2 mode. Okay, because this is for those who want to learn more. Okay. Yes. So triple helix is formed. This pro-collagen gets released into the extracellular space. And what happens in the extracellular space? Those extra chains which have not formed the helix will be removed. That will be removed by aminopeptidases. That is how pro-collagen becomes tropocollagen. After you form tropocollagen, lysyl oxidase starts acting on it. And this lysyl oxidase needs what? This is the enzyme which needs copper. So they form a quarter staggered alignment like this. Yeah, what do you mean by quarter staggered alignment? In every tropocollagen, 3/4 of it will be overlapped by another tropocollagen. This is called as quarter staggered alignment. And after this, lysyl oxidase will start acting on it to cause aldol condensation. And this lysyl oxidase is dependent on this is dependent on copper. Okay, so that is why, what did I tell you? That is why I told you for collagen maturation, you don't only need ascorbic acid, you also need copper. If there was a choice which had both copper and ascorbic acid, please go for it. Got it? Which immunoglobulin is mega? I will definitely continue. Which immunoglobulin is present in serum or plasma at the highest concentration? What is the right answer? The right answer is immunoglobulin G. Okay, which is present in the highest concentration? It is immunoglobulin G. So what are the facts that you need to know about immunoglobulin G? This is responsible for secondary immune response. We know that, right? This is responsible for secondary immune response, and because it is a monomer, it can cross the placenta and it can enter into fetus. So it helps in fetal protection. So IgG is the immunoglobulin which can cross placenta. After IgG, which is more common, it is IgA. And because IgA is responsible for surface immunity in all body secretions. Suppose the question was, instead of in serum or plasma, if the question was which is the highest in body secretions, then your answer has to be IgA. It is responsible for surface immunity. And as far as IgM is concerned, this is responsible for primary immune response, and this is a pentamer. Because it's a pentamer, it's a very large molecule, so it cannot cross the placenta. Do you understand this? If you know these facts, that's more than enough. Okay, yes. So the most common one is IgG followed by IgA. IgM is primary immune response which can cross the placenta. Now nitric oxide is formed from, I got different question. They asked me highest molecular weight. If it's highest molecular weight, it is IgM, Shubham. IgM is a pentamer, right? Yeah. Nitric oxide is formed from which amino acid? Answer is arginine. Yeah, we know nitric oxide is otherwise called as endothelium derived relaxing factor. Yes, you're right, KU. Yeah, it is endothelium derived relaxing factor, and as the name indicates, it's released by endothelium. When endothelial nitric oxide synthase acts on arginine, converts it into nitric oxide. But when inducible nitric oxide synthase acts on arginine, that is also converted to nitric oxide. That happens in macrophages, wherein they help us immune defense system. Okay, so you have endothelial nitric oxide synthase and inducible nitric oxide synthase. Both will be from arginine. Okay, now what are the other specialized products that you get from arginine? Can you all think and tell me from arginine? What are the other specialized products that you get? It is creatine. What is the mnemonic that you can use for understanding or for remembering what are the amino acids that are necessary for creatine synthesis? For creatine synthesis, it is GAME. What does GAME stand for? Glycine, arginine and methionine. Okay, glycine, arginine and methionine are the three amino acids which are necessary for creatine synthesis. And additionally, don't you know that when arginase acts on arginine, it becomes ornithine. So arginine is also precursor for ornithine. From ornithine, you get many polyamines. From ornithine, you get spermidine, spermin, putrescine. So all these polyamines are indirectly from arginine. So this can be asked as an MCQ in your NEET PG. If they ask you what are the specialized products that you get from arginine, what should be your answer? The first answer is nitric oxide. Second one is creatine, GAME, glycine, arginine and methionine. And the third one is you get ornithine from arginine, and from ornithine you get putrescine and spermin. Okay, good. Now tryptophan, I already told you. Can anyone answer this now, please? Tryptophan, what are the specialized products that you get from tryptophan? You get serotonin and niacin. So this is an image-based question that was asked. Remember, a patient presented to the OPD with liver damage. The picture depicts a patient having their eyes examined. Which of the subsequent factors is the cause of this condition? Excellent. Serotonin, niacin. I'm very happy that most of you are active in the live chat. So if I ask you to describe this cataract, what will be your answer? How does it look? Doesn't it look like sunflower? Yeah, it looks like sunflower. So what is the combination here? There is a patient who is presenting with liver damage with sunflower cataract. So this is hepatolenticular degeneration or Wilson's disease caused by copper toxicity. So tell me what is the right answer here? Very good. Yes, sunflower. Excellent. So hi Prathamesh. Yeah, what is the answer? It is copper. Okay. So had it been glucose, yeah, if the factor was glucose, as which happens is if excess glucose has caused cataract, as which happens in juvenile diabetes, how will you describe the shape of the cataract? That will be a snowflake cataract. Juvenile diabetes, can you see that here? Juvenile diabetes is characterized by what kind of cataract? Snowflake cataract. Okay. And had it been galactose, which is the cause? Yes, sorbitol is the reason. Okay. So galactose, if galactosemia was the cause and if galactose accumulation is the reason, then the cataract would look like oil drop. If the image was oil drop cataract, then it is galactose, which is seen in galactosemia. Got it? Yes. And for more information, what is responsible for snowflake cataract and diabetes? Which alcohol is responsible? Sorbitol is responsible for diabetic cataract. Which alcohol is responsible for galactosemic cataract? It is galactitol, otherwise called as dulcitol. Okay, so please remember, sunflower cataract is Wilson's disease or copper toxicity. Snowflake cataract is juvenile diabetes caused by sorbitol. Oil drop cataract is galactosemia caused by dulcitol. Okay, so I will quickly tell you few facts about Wilson's disease because Wilson's disease is also often asked. So Wilson's disease is caused by the defect of ATP7B in chromosome 13 in chromosome 13. So Wilson's disease is caused by a mutation of ATP7B in chromosome 13. And if you are saying, I always get confused between Menkes disease and Wilson's disease. Menkes is ATP7A. Yeah, Menkes is ATP7A. In alphabetical order, which alphabet comes first? M comes first, and that is ATP7A. W comes next, and that is ATP7B mutation. And what is the function of ATP7B? It has got two functions. One is it is responsible for secreting copper into bile. It is responsible for secreting copper into bile, or in other words, it helps in excretion of copper. And the next function of ATP7B is that it helps in the incorporation of copper into ceruloplasmin. So have you memorized it? What is the function of ATP7B? Two functions. One is it's responsible for copper excretion through bile. Second is it helps in the incorporation of copper into ceruloplasmin, because only in the form of ceruloplasmin copper will be able to reach other tissues wherein they get incorporated into enzymes. So if both these functions are not performed, what will be the effect? When copper is not excreted into bile, copper accumulates, and that causes copper toxicity. And copper toxicity damages liver and lenticular nucleus. It causes liver and lenticular nucleus. That is why the name hepatolenticular degeneration. And because there is something called as lens here, though it refers to lenticular nucleus, this lens you can use to remember that there is some change that is happening in lens in Wilson's. What is that? It is sunflower cataract. And closely related to lens, there is something which is happening in the cornea. What is it? Kayser-Fleischer ring. Right? Please remember Kayser-Fleischer ring, which is a very thin rim in the corneal limbus. In the corneal limbus, you will see brownish rim. And that is Kayser-Fleischer ring, which means copper is accumulated there. So that's about hepatolenticular degeneration. And because copper is not getting incorporated into ceruloplasmin, ceruloplasmin loses its stability. Only after apoceruloplasmin accepts copper, it becomes stable. Now that its stability is lost, ceruloplasmin will be degraded quickly, and that is responsible for low ceruloplasmin in Wilson's disease. So the take-home message for all those who are watching this session is the low ceruloplasmin that is observed in Wilson's disease is not the cause of Wilson's disease, it's the effect of Wilson's disease. It is because copper is not getting incorporated into ceruloplasmin, ceruloplasmin gets degraded. Okay, and additionally, what will happen to serum copper level? The major form in which copper is transported in serum is ceruloplasmin. Because there is no ceruloplasmin, serum copper level will be low, though it is a disease of copper toxicity. Are you all listening? Yeah, though it is a disorder of copper toxicity, serum copper, paradoxically, serum copper in Wilson's disease will be low. And because there is nothing to carry copper in a safe way, the copper that is supposed to be there in the blood will get filtered along the glomeruli, will be seen in the urine. So urinary copper will be high. So have you understood this triad? This triad can be used for diagnosing Wilson's disease. What is the triad? Low serum ceruloplasmin levels, low serum copper, high urinary copper. Okay, so what are the values that you should remember? Serum ceruloplasmin will be less than 0.2 grams per liter. Yeah, the first value that you should check is serum ceruloplasmin level is less than 0.2 grams per liter. Urinary copper should be high. How high should it be? It should be more than 100 micrograms per 24 hours. Urinary copper should be more than 100 microgram per 24 hours. Even if it is more than 40 microgram per 24 hours, your suspicion should be higher. Okay. But what is the gold standard method for diagnosing Wilson's disease? It is liver copper. So liver biopsy has to be done, and if the liver copper concentration is more than 250 microgram per gram of tissue, that is diagnostic of Wilson's disease. So have you all memorized this? Yeah, so please memorize these three diagnostic criteria for Wilson's disease. What did I tell you? Urinary copper will be higher than 100 microgram per 24 hours. Serum ceruloplasmin will be less than 0.2 gram per liter. And then liver copper concentration will be more than 250 microgram per gram of tissue. Okay, good. Yes, Shubham, very good. So Deeksha, you're also right. So that's all about Wilson's disease. This I would say is a very simple question, right? Breastfeeding is contraindicated in which of the following conditions? What would be a right answer? So there are totally 18 MCQs in biochemistry. Okay, either directly or indirectly related to biochemistry. There are totally 18 MCQs, and all 18 MCQs I'll explain now. So breastfeeding is contraindicated in, yes, galactosemia. Why is it contraindicated in galactosemia? Because breast milk has got lactose. And when lactose enters into intestine, lactase will digest it to give glucose and galactose, because lactose is a disaccharide made up of glucose and galactose. Then galactose enters into the child system. If there is a galactose metabolism disorder, this is going to precipitate every feature which you have to avoid. And that is why breastfeeding should be avoided in galactosemia. This is a very simple question again. The anterior incisors of a child with white patches turn brown following over supplementation of which of the following? What is this? Galactosemia, Shubham. Galactosemia is not caused by aldolase B defect. Galactosemia, classical galactosemia, is caused by the defect of galactose 1-phosphate uridyl transferase. Okay, aldolase B defect causes hereditary fructose intolerance. So please don't get confused here. Galactosemia, classical galactosemia, is caused by the defect of galactose 1-phosphate uridyl transferase. And then what did I tell you? Yeah, hereditary fructose intolerance is caused by the defect of aldolase B. Good. So what is answer here? This is dental fluorosis, right? So answer is fluorine in water. There is excess fluorine in water. This is dental fluorosis. And dental fluorosis is an enamel hypomineralization defect, right? It's an enamel hypomineralization defect. And this is caused whenever a child is exposed to fluorine at a concentration more than 1.5 milligram per day. If fluoride intake crosses 1.5 milligram per day in a child, that can result in dental fluorosis if the exposure happens before 7 years of age. And why have I written it as more than 1.5 milligram per liter? It's not a transcriptional error. I wanted to tell you, if the fluorine content of fluorine content of water is more than 1.5 milligram per liter, assuming that a child would drink 1 liter of water, this is dangerous. That can cause dental fluorosis. Do you understand that? Yes. So this I would say is a very interesting question. Yeah, that's why I said there is a right combination of all types of MCQs here. Which of the following is true regarding creatinine clearance? Creatinine clearance is lesser than inulin clearance, more than inulin clearance, equal to inulin clearance, none of the above. What do you think is the right answer? Creatinine clearance is greater than inulin clearance. That is why we say creatinine. It is choice B. All of you? It's not A, it is choice B. Creatinine clearance is greater than inulin clearance. I will tell you the reason, after which you will never get confused. Yeah, you will never have a doubt about it. Okay. So why is creatinine clearance greater than inulin clearance? Because for you to measure clearance or for you to measure glomerular filtration rate, you need a substance which gets only filtered along the glomerulus. It should be neither reabsorbed nor secreted. Don't we say that always? For you to say that a particular substance is an ideal substance for measuring clearance or for measuring GFR, that substance should be only filtered along the glomerulus. It should be neither reabsorbed nor secreted. And that way the ideal substance is inulin. It is only filtered, neither reabsorbed nor secreted. But your creatinine is not only filtered, it is also secreted. Do you understand this? It's not only filtered, it's also secreted, which means what do you think about urinary concentration of creatinine? Urinary concentration of creatinine is going to be higher. And what is the formula for GFR or for clearance? The formula is UV by P, right? The formula for clearance or, thanks Kichu. Yes, so the formula for GFR is UV by P, where U is nothing but the concentration of creatinine in urine. Just now I told you creatinine concentration urine is higher. The numerator is higher. So clearance is going to be falsely elevated. That is why we say creatinine is not the ideal substance for measuring GFR. Do you all understand this? So why is it not the ideal substance for measuring GFR? Because it's not only filtered, it's also secreted. So the concentration of creatinine in urine is higher. In the formula for clearance, you have the concentration of urine in the numerator. So clearance will be falsely elevated. Got it? Thank you, Madhu. You're writing NEET, PG and INI-CET. Okay, this session will definitely be of use to you, Megha. Okay. So this is the next question. This is again a good question, I would say. This is almost like an USMLE question. A patient who was in excruciating pain all over his body was taken to the hospital. In recent years, he has experienced these incidents frequently. When exercising vigorously, the ache begins. Anemia was detected by blood examination along with elongated red blood cells as opposed to concave ones. So though the history is a very lengthier one, you're from Pakistan, yeah, from wherever you are, if you're a medico, this is essential. Okay, so most of you have answered it right. Yes, Shubham, you're right. Answer is choice C, substitution of glutamic acid by valine. Though the history is a lengthier one, they've given you the diagnosis straight away. What have they told you? They've told you that there is sickle cell anemia. They're just asking you about the mutation. What or which mutation causes sickle cell anemia? In sickle cell anemia, 6th codon, instead of coding for a polar amino acid glutamic acid, is replaced by a non-polar amino acid valine. So what is the right answer here? The right answer here is choice B. Okay, so I am going to tell you now a bit about sickle cell anemia molecular basis. Watch this carefully. In sickle cell anemia, there is a mutation because of which the 6th codon of beta globin gene, yeah, 6th codon of beta globin gene usually is GAG. Because of the mutation, it is replaced by GTG. So can you tell me what kind of mutation is this? There is a substitution. If there is a substitution, what will you call it as? You will call it as a point mutation. So point number 1 about sickle cell anemia is that it is caused by a point mutation. What kind of point mutation is it? Adenine is a purine, thymine is a pyrimidine. Purine is replaced by a pyrimidine. Mute your phone. Oh. Is this okay now? Is it okay now? Yeah. So there is a point mutation. Because of this point mutation, what has happened? A is replaced by T. Oh, thank you. So A is replaced by T. A purine is replaced by a pyrimidine. So what will you call it as? You will call it as a transversion. Okay, so what are the facts that you have learnt about sickle cell anemia? It is caused by a point mutation in the 6th codon of beta globin gene, and it is a transversion mutation. And usually GAG codes for a polar amino acid glutamic acid, GTG codes for a non-polar amino acid which is valine. And this 6th amino acid in a normal person, in you and me, or even in a person with sickle cell anemia, this 6th amino acid is always concealed in the globin. Yeah, it is always concealed. Only after dehydration or only after deoxygenation, the 6th amino acid comes to the surface. When it comes to the surface, if it's the usual polar amino acid glutamic acid, it does not cause any defect. But if that is replaced by valine, valine is a non-polar amino acid which has got hydrophobic interaction with anything which is non-polar nearby. And what is nearby? RBC membrane is nearby. And you know, any membrane is non-polar. So this creates a sticky patch. And this valine goes and sticks to the RBC membrane. So all globin chains come and get deposited on the RBC membrane because of the hydrophobic interaction. And when something gets deposited on the RBC membrane, the deformability of RBC membrane is lost. So when RBCs try to squeeze through splenic sinusoids, they are no more deformable. So the membrane will get pinched off, and that is why they are no more concave shaped. Instead, what are they? They become sickle shaped. So this is called a sickling crisis. So what is the reason for sickling crisis? It is only because of, thank you all. So what is the reason for sickling crisis? Sickling crisis is predominantly because of the sticky patch that is created by polar amino acid being replaced by non-polar amino acids. Okay. Yeah, dehydration precipitates, Raj. Both dehydration and deoxygenation, both will precipitate. So what is the right answer? The right answer here is substitution of glutamic acid by valine at the 6th position. So this is the next question. What is the right answer, all of you? Yes. Oh, you say it's niacin? Very good. So what do you observe here? If you summarize this question, whenever you're given a case-based MCQ, try to summarize the findings. Okay. So what is that you observe here? Diarrhea, and then there is dermatitis and dementia. Diarrhea, dermatitis and dementia. It is 3 Ds of pellagra. Right. 3 Ds of pellagra will be caused by the deficiency of B3. What is B3? Niacin. So what is the right answer here? The right answer here is choice B. Very good. Yes. I don't prefer to say the 4th D. Yes. So this is the next question. A woman with complaints of pain, tingling sensation, numbness of the foot has a history of taking vitamin supplements. Which of the following is responsible for this patient's condition? What is the right answer? Xanthuronic acid. Okay, good. So Hashirama is asking about xanthuronic acid. Xanthuronic acid is estimated whenever you suspect B6 deficiency. Is that clear? That is not for niacin deficiency. If you suspect B6 deficiency, 6 ends with X. Right? 6 ends with X. That is when what will you estimate? You will estimate xanthuronic acid levels. After what load? After tryptophan load. Okay, X is followed by Y. So if you suspect B6 deficiency, what will you estimate? Xanthuronic acid levels after a tryptophan load. Is that clear, Hashirama? Okay. So now, what do you think is the right answer? So before we start jumping to conclusions, yeah, the history says the person has taken some vitamin, and because of that there is a toxicity, and that toxicity is presenting with neuropathy. That is a summary, right? Some supplement has been taken by an individual, there is a toxicity because of the vitamin supplement, and the person is presenting with neuropathy. Before we can start identifying which vitamin toxicity can cause neuropathy, out of these choices, can we try to find out which vitamin is prone to cause toxicity? Can you tell me which of the following vitamins is prone to cause toxicity? It is predominantly vitamin A, right? Because vitamin A is a fat soluble vitamin. I am not giving you the answer, I am helping you exclude choices. Okay, so vitamin A is the only fat soluble vitamin here. and this is the only vitamin which can be stored by your body. This is more prone to cause toxicity. But vitamin A toxicity presents as what? It will present as irritability, lack of appetite, vomiting. Right? Irritability, lack of appetite, vomiting, headache, all signs of increase in intracranial tension. Vitamin A toxicity will present with all signs of increase in intracranial tension. That is why we say it is one of the causes of pseudotumor cerebri. It looks like a tumor, but it's not tumor. It is caused by vitamin A toxicity. It also presents with bony exostosis. Do you find any of these features here? No, they have not mentioned anything about vomiting, nothing about headache, nothing about increase in intracranial tension, nothing about exostosis. So we have excluded vitamin A toxicity. Got it? Now, beriberi is thiamine deficiency. Here we are looking for some toxicity. So I have excluded choice B. Now, increase vitamin B12. I think one of you was saying you got confused between, yes, Dr. Shubham was saying you were confused between B6 and B12. That's a reasonable confusion. So, increase vitamin B12 can be a sign of solid tumors. Okay, in serum, if vitamin B12 is elevated, that can be a sign of solid tumors, or it can be a sign of liver damage. But if a person takes lots of vitamin B12 and if there is a toxicity, they say it presents only with dermatological findings, because it's predominantly because of excess cobalt and it causes only dermatological finding like acne. It does not present with neuropathy. So what are you left with? You are left with something called as mega vitamin B6 syndrome. What do you call it as? We call it as mega vitamin B6 syndrome. So paradoxically, vitamin B6 is prescribed for neuropathy, but when there is excess vitamin B6, that also causes neuropathy. And though it is a water soluble vitamin, it can cause vitamin B6 toxicity when the intake is more than 1000 milligram per day. Okay, when the intake is more than 1000 milligram per day, it can cause toxicity. And why does it cause neurological manifestations? There are so many hypotheses behind it, but the one which is reasonable here is when there is excess B6 intake, pyridoxal kinase will not be able to convert B6 to pyridoxal phosphate. So there is excess free B6, which is not the coenzyme form. And this excess B6 will competitively inhibit pyridoxal phosphate acting on enzymes. Is it not a good reason? Yeah, that is why B6 toxicity causes neuropathy. Got it? Yeah, folate supplement can cause B12 deficiency. You're right, methylfolate trap. The reverse is true. Yeah, so now do you understand why excess B6 can cause neuropathy? When the person takes excess B6, it's not getting converted to pyridoxal phosphate, and the excess B6 will competitively inhibit pyridoxal phosphate being acting upon. It inhibits pyridoxal phosphate from acting on enzymes. So it causes neuropathy. This is called as mega vitamin B6 syndrome. Okay, so what is the right answer here? The right answer here is hypervitaminosis B6. Vitamin A deficiency leads to what? Vitamin A deficiency, it's a very simple question, right? It leads to xerophthalmia. Because what is beriberi? Beriberi is caused by thiamine deficiency. What is pellagra? Pellagra is caused by, just now we discussed, niacin deficiency. And neuropathy can be caused either by B6 deficiency or by B12 deficiency. Okay, B6 or B12 deficiency. So what is the right answer here? Yes, all of you are right. The right answer here is xerophthalmia. Now, I will use this chance to tell you about WHO staging. Yeah, WHO staging of vitamin A deficiency manifestation in the eye. So what are the WHO categories? WHO staging, WHO grading. The first one is XN, right? We have XN and then X1A, X1B, X2, X3A, X3B, XS and XF. So this is WHO grading of vitamin A deficiency. I am going to write down what does XN mean. XN means nyctalopia. So this is the earliest sign of vitamin A deficiency in the eye, right? So XN is nyctalopia. What is X1A? Remember, difficult to remember, it's very easy. Okay, X1A is conjunctival xerosis. conjunctival xerosis or xerophthalmia. And X1b, B for Bitot spots. Okay. And then X2, conjunctiva is over, now it is cornea. So it is corneal xerosis. X2 is corneal xerosis. Following dryness of cornea, there will be softening of the cornea, which is keratomalacia. So X3A and X3B both are keratomalacia. If keratomalacia involves less than 1/3 of the cornea, that is X3A. If it involves more than 1/3 of the cornea, it is X3B. And then XS, after keratomalacia softening, there should be scarring, right? So that is corneal scar. And finally, it is xerophthalmic fundus. Is it not simple now, Megha? It's simple, right? So you start with Xn, starts with nyctalopia. X1A is conjunctival xerosis. X1B is Bitot spots. What is Bitot spot? It's like a foamy structure which is nothing but keratin debris. And keratin debris is more common on the temporal side. Yeah, that also can be asked. So Bitot spots on the temporal side is nothing but keratin debris. That is X1B. And then X2 is corneal xerosis. And then X2, X3A, X3B both are keratomalacia involving less than 1/3 and more than 1/3. And then XS is corneal scar and XF is xerophthalmic fundus. At the end of the session, please tell us how to deal with exam day fever and anxiety and fear of impending doom after looking at questions during exam without even reading them, that how easy they are. Definitely awesome, doctor, I will tell you. Yeah, I will definitely tell you. Okay, so that's about WHO grading. Now, what is the biochemical basis of conjunctival xerosis and corneal xerosis and vitamin A deficiency? Why should it happen at all? It is based on the fact that vitamin K is in three forms, right? Vitamin A is in three forms. One is retinol. The alcohol form is retinol. The aldehyde form is retinal, and the acid form is retinoic acid. And the alcohol form is the form in which vitamin A is absorbed, transported and stored. Okay, the alcohol form is the form in which vitamin A is absorbed, transported and stored. Okay, this was asked once in FMGE. Now the aldehyde form retinal. In retinal, do you see retina? In retinal, you see retina. So this is the one that is present in eye. When I say it's present in eye, it is present in rods and cones in the form of rhodopsin and conopsin. So what is rhodopsin? Until stimulated by light, rhodopsin is levensis retinal in the center that is surrounded by opsin. Do you understand this? So what is present in the eye? Retinal, aldehyde form. In what form? Until stimulated by light, it is levensis retinal in the center surrounded by opsin. So that's about retinal. And then retinoic acid. There are two forms of retinoic acid. One is all trans retinoic acid. The other one is 13-cis retinoic acid. So what are the two forms of retinoic acid? One is all trans retinoic acid. The next one is 13-cis retinoic acid. And here this 13-cis retinoic acid is the one which suppresses keratinization of epithelium. What is its main function? It is to suppress keratinization of epithelium. So tell me what is expected in vitamin A deficiency? No suppression of keratinization. So everywhere there is keratinization. And keratinization of the skin is the reason for what? Keratinization of the skin is the reason for phrenoderma. Have you learnt about phrenoderma? Phrenoderma is nothing but, are you all listening? Yes. So phrenoderma is nothing but follicular hyperkeratosis. On the extensor surfaces of the elbow, you will see small papular lesions with keratin plug in the tip. That is phrenoderma caused by vitamin A deficiency, because 13-cis retinoic acid is deficient and its main function is to suppress keratinization of epithelium. And when you don't suppress keratinization of conjunctiva, that causes conjunctival xerosis or corneal xerosis. And excess keratin debris is the reason for Bitot spots. Is that clear? It's very simple now, right? Yeah. So that's about vitamin A deficiency. So vitamin A deficiency leads to xerophthalmia. In liver, ApoB gene is completely translated to ApoB100. Yeah, did you see this question? Do you all remember this question? This is a very favorite concept that I would like to explain to all students. So in liver, ApoB gene is completely translated to ApoB100 and in intestine it is translated to ApoB48. Which of the following mechanisms explains this? What is the right answer? The right answer is RNA editing. Okay, the right answer here is RNA editing. So let me tell you first what is RNA editing and then we'll start discussing what happens in ApoB formation. So RNA editing is nothing but it's a process where you edit some of the nucleotide sequences of the fully formed mRNA only in specific tissues. So what is RNA editing? In RNA editing, you edit some of the nucleotide sequences of the fully formed mRNA in specific tissues so that the amino acid sequences of the proteins which you get out of them also get altered only in specific tissues. This tells you how can one gene give rise to different protein products in different tissues. Do you understand this? That is not ApoB4 deficiency, that is ApoE4. Shubham? Yeah, what you are talking about is ApoE4 which can cause Alzheimer's. We are not discussing about E, we are discussing about ApoB. Okay? Yeah. So what is RNA editing? Can I repeat it? RNA editing is a process where you edit some of the nucleotide sequences of the fully formed mRNAs only in specific tissues so that amino acid sequences of the proteins which you get out of them also get altered only in few tissues. This tells you how can one gene give rise to different protein products in different tissues. I am going to give you an example. Example is ApoB48 formation. ApoB48 is an apoprotein of which lipoprotein, all of you? ApoB48 is an apoprotein of chylomicron. And where is chylomicron formed? It is formed in the intestine. So ApoB48 is an apoprotein that is synthesized in the intestine. Whereas ApoB100 is an apoprotein of VLDL. ApoB100 is an apoprotein of VLDL which then gets transferred to LDL. And where is VLDL formed? That is formed in hepatocytes. Okay. So ApoB48 is a protein that is formed in enterocytes. ApoB100 is a protein that is formed in hepatocytes. But interestingly, both these proteins are product of one common gene which is ApoB gene. Okay. So this ApoB gene undergoes transcription. This ApoB gene undergoes transcription to give rise to the same primary transcript in both liver and in intestine. And this primary transcript undergoes the same post-transcriptional modification to form the same functional mRNA in both liver and in intestine. But after the functional mRNA is formed, this functional mRNA leaves the nucleus and it reaches the cytoplasm. After it reaches the cytoplasm, there is a change that happens only in enterocyte. So let's consider that this is enterocyte, this is hepatocyte. So after the functional mRNA has reached the cytoplasm, there is a change that happens only in enterocyte. Enterocytes have an enzyme by name cytidine deaminase. Repeat it. What is the enzyme? The enzyme is cytidine deaminase which deaminates cytidine of a codon. It deaminates cytidine of a codon CAA. In both the places there is CAA, but one in enterocyte, cytidine deaminates cytidine of a codon CAA, converting CAA to UAA. What is UAA, all of you? I will be happy if any one of you can answer this. What is UAA? Yes, ApoB100, I told you Shubham, ApoB100 is first attached to VLDL and then it gets transferred to LDL. It is first attached to VLDL. Okay. Yeah. So what is UAA? UAA is a stop codon. So only in enterocyte there is premature termination of protein synthesis. So enterocyte produces a truncated protein which has only 48% of the amino acids which are produced by the protein in the hepatocytes. So hepatocyte protein is a large protein, complete protein. So that complete protein is called as ApoB100 and the truncated protein which has got 48% of the amino acids will be called as ApoB48. Do you all understand this? Yeah, this is how one gene, what is the one gene here? ApoB gene can give rise to different proteins in different tissues. It forms ApoB48 in enterocyte. It forms ApoB100 in hepatocytes. Have you all understood this? Got it? Yes. So ApoB48 formation is an example of what? It's an example of RNA editing. What is RNA editing? You edit some of the nucleotide sequences of the fully formed mRNAs only in specific tissues, so that amino acid sequences of the proteins which you get out of them also get altered only in specific tissues. This tells you how can one gene give rise to different proteins in different tissues. Okay. So what is the right answer here? The right answer here is RNA editing. So this was another question, right? How many of you remember this question? I was not given this question, but some students were telling me that there was a question on P43. Yeah, which of the following about P43 is true? Apolipoprotein function. Hashirama, are you asking me what are the functions of apoproteins? Apoproteins can have various functions. One function carried by apoproteins is they act as ligands for the receptors which are concerned with their metabolism. Yeah, they act as ligands for the receptors which are concerned with their metabolism. For example, ApoE. Yeah, Shubham was telling about ApoE4, right? So ApoE is an apoprotein that is accepted by remnant receptors of the liver. ApoE is accepted by remnant receptors of the liver, or ApoE is accepted by LDL receptors of the liver. So that is one function performed by apoproteins. Another function performed by apoproteins is that they act as regulators for enzymes. Yeah, they act as regulators for enzymes which are concerned with their metabolism. For example, ApoC2 activates lipoprotein lipase. ApoC3 inhibits lipoprotein lipase. Do you all understand this? So these are the two functions that are carried by apoproteins. Hashirama, have you understood it? They either act as ligands or they act as regulators for enzymes. Okay, so there was no question related to P43. No question like this. Okay, then it's fine. If you didn't see any question related to P43, all that I want you to know about P43 is that P43 is related to telomerase. Okay, so telomerase is responsible for maintaining the telomeric length, and P43 is a telomerase associated protein which helps telomerase to be retained within the nucleus. Okay, if there was no question, then we don't have to discuss about it. Yeah. Okay. So that's all about questions in biochemistry. I hope I explained all questions and I gave you answers for all questions. And before we end the session, I would like to tell you all about the latest legendary elite pack. So this elite pack will give you an access to all updated new video lectures of all 19 subjects. And then you will also have an access to next edition QBank with 70% clinical questions. Even in FMGE, did you see so many clinical case-based MCQs? And next will be predominantly based on clinical case-based. And then notes will be aligned to the lectures. Enjoy the session. Thank you. What were the other questions, Sudiksha? If you can remember, I will tell you. I can explain you. Thanks, Raj. So there are treasures. Apart from QBank, there are treasures which will help you in quick revision, rapid revision and snapshot videos, mock tests. So there are so much beyond what you can expect in elite pack, and that will help you get ready for NEET or next exam. Okay, so do prescribe for it at the end of the session. Yes, question. Awesome doctor wants me to say something about how to avoid fear. So what I would like to tell you all is, already you have achieved lots, haven't you? Yeah, getting into a medical college, reading all 19 subjects and coming out with flying colors by itself is an achievement. So your bread and butter are already assured of, and what you're aiming for is something which is beyond that, right? That is beyond that. So you have that assurance in mind. You don't have to worry much about it. Okay, that is point number one. And point number two is, it all depends on how you learn. If you learn all 19 subjects conceptually, however twisted the question is. So awesome doctor was saying, even before I can read the question, find out whether it's easy or tough, I get nervous. Yeah, so when will you have the confidence to face the question? Only when you have learnt it conceptually. Okay, if you memorize everything factually, then you will be dependent on a pattern of question. If the pattern gets changed, then you will fumble. Okay, so try to read everything conceptually and try to enjoy the process of learning, because it's all about you becoming a good doctor. Yeah, you become a good clinician. It is not just about you clearing an FMG exam. It is not just about you getting a good rank or mark in the NEET PG. It is ultimately about how good a clinician you are going to be at the end of the day. So you should relish the process of learning, learn everything conceptually, and then do enough number of grand tests. Okay, so irrespective of the exam which you are going to write, attempt any grand test that comes on your way, because more the number of grand tests, more familiarized you will be about time management, more familiarized you will be about the pattern of question that will be asked. Okay, and every question will look like a familiar question. So try to write as many grand tests as possible. Be confident. Okay, take control of whatever process you are involved in and enjoy the process. Okay, so don't get nervous. It's nothing. Nothing. You have achieved lots. Yeah, have that in mind. Okay, thank you all. See you all again with another session. Reason for thiamine deficiency except was a question. Chronic alcoholism will definitely cause thiamine deficiency. Veganism, bariatric surgery, chronic use of diuretics. Bariatric surgery, chronic use of diuretic, veganism. I'm very sure about choice A being a cause of thiamine deficiency. Veganism should not cause thiamine deficiency. Veganism causes only B12 deficiency. So I think I would go for B. Okay. Which was associated with oxidation? What was the question exactly, Sudiksha? You mean electron transport chain complexes? Which hemoglobin uses ferrous ion? What was the question? I think I missed it. Okay, can you do something? I will write my mail ID here. You can post your questions. Yeah, I will explain that in the next YouTube session. Okay. Public demand skincare routine. I don't follow any routine actually. I don't know what to say for that. Probably I work out regularly. That is the only thing that I do. Other than that, nothing. When we eat protein-rich diet with least carbohydrates, why we cannot see hypoglycemia? I think I've already explained this MCQ in a different session. Dhruvin Patil, can you please message that or mail that to my ID? I will take this up in the next YouTube session. Okay? Yes. So thank you all. See you.